So good afternoon and welcome to our session of Global Refugee and Immigrant Health during a COVID pandemic era, experiences, status, and perspectives on racial disparities. I will start by introducing myself. I am the moderator for today's panel. My name is Fatima Az-Zahra Selmi. I was born and raised in Morocco. I am currently pursuing an MPH in Community Health Education at UNC Greensboro. I am also a graduate research assistant on projects addressing mental health as well as COVID-19 challenges in refugee and immigrant populations in the Piedmont Triad of North Carolina. So joining us today, our three esteemed panelists, Dr. Carmen Monaco, who is an associate professor at the Joint Master and PhD Social Work programs at North Carolina A&T State University and UNC Greensboro. Dr. Dia Abdu. She's the director of the Center for New North Carolinians at UNC Greensboro, and Dr. Sharon Morrison, who is a professor in the Department of Public Health Education at UNC Greensboro. So I want to thank everybody for being here. So I will be asking each of you a series of questions, and in the interest of time, I would like each of you to keep your responses to no longer than 3 minutes. So starting off with Dr. Monaco, this is just an introductory question. So tell us about who you are, what you do, and the communities that you engage with, that you serve or research with.
Thank you, Fatima. My name is Carmen Monico, and I actually came to the U.S. seeking refuge during the Civil War in El Salvador, where I was born. I was one of over 1 million of people seeking refuge from that country, but more from Central America. And later were followed by another million from the region. Most of people living in those days, in the 80s when I left, as well as in the 19th and 20th century, were seeking protection actually from various forms of violence, including domestic violence and community violence, as well as from natural disasters, such as the one that just recently took place. The reasons then of leaving the region continue to be present, although there's have been endemic poverty and other reasons like gang, for example, persecution. These are kind of the push factors that continue to be prevalent and the reason for why people are leaving the region and seeking refuge in the US, rejoining some families and previous people from the same community. Before academia, I actually was an organizer of self-help services like other speakers today in the Washington, D.C. area, and advocated for temporary protection status in the US. I'm now as an associate professor educating and training social workers at the master's and PhD level, teaching from my own experience as well as my professional experience, not just from theory. Global migration is my main research area. I have published extensively on beneficiaries from various programs during the deferred action for children, and also have been addressing the situation of immigrants and refugees as a balloon effect of the US foreign and drug policies that have resulted in the displacement of many people, including and lately, especially unaccompanied minors and their families from Guatemala, El Salvador, and Honduras. I'm now conducting research on immigration detention centers under the COVID, contributed to 2 book chapters on the impact of the pandemic on immigrant and refugees. And I'll be speaking and sharing with you from that experience and expertise. Thank you.
Thank you, Dr. Monaco, for introducing yourself. And next will be followed is Dr. Dia Abdu.
Thank you so much for having me here today. So I'm Dr. Dia Abdo, and I am a professor of English, as well as the founder of an initiative called Every Campus a Refuge. Today I'm representing the Center for North Carolinians at UNCG, where I am the director. I am a first generation Palestinian, born and raised in Jordan to Palestinian refugee parents, and I'm an immigrant to the US. I have been working with refugees for the past few years, initially through my program, Every Campus a Refuge, which mobilizes campuses around the US to use their resources to support and host refugees on campus. At the Center for North Carolinians, where I'm currently serving as a director, we serve over 2,000 refugees and immigrants annually who come from over 30 countries, as well as at-risk Latinx families. And we focus on promoting access and integration through support with employment, education, as well as access to health and human services, and especially social determinants of health, especially housing. The CNNC serves low-income immigrants and refugees, and the vast majority of those are obviously racial and ethnic minorities. More than 10% of Guilford County's population is foreign-born. On average, 1,800 new immigrants and refugees from around the world make Guilford County their home each year, and Greensboro is a resettlement hub for the Eastern Seaboard. Guilford County specifically is a top refugee receiving county in the state. The CNNC community itself, our staff are racially and ethnically diverse group with a majority staff being women of color. We serve especially uninsured refugee and immigrant adults through our Immigrant Health Access Program at the CNNC. And it's the experiences of our service and support work through that program that I'll be speaking to today. Thank you.
Thank you, Dr. Abdu, for introducing yourself. Next will be Dr. Morrison.
Hey, well, thank you all, and I'm excited to be on this panel. I'm Dr. Sharon Morrison. I am a professor in the Department of Public Health Education at UNC Greensboro. I am an immigrant. I am from the sunny island of Jamaica, where I was raised. And I came to the United States more than 30 plus years ago. Came through family unification process. And it was interesting, came in the mid to late 80s when there was an acute health professional shortage. And so through that process, family members coming to the United States, I came here and pursued my education. I like to say that I have been a public health advocate since my teens, been the recipients of many public health strategies and good ones, and seen some fail. So I've got several years of working in public health. Prior to coming to UNCG in 2001, I worked and approached public health from the bench science perspective, and I thought at that time this was a good way to approach looking at infectious diseases. Later, I transitioned and excited to begin to look at public health from a population-based perspective. I teach courses in the department that look at public health diseases, but I have the pleasure of teaching courses that look at global health and immigrant and refugee health. I have led study abroad programs to different regions of the world. More recent, I've looked at refugees and their protection and health and well-being in global contexts. My main areas are looking at chronic and emergent conditions in refugee and immigrant newcomers to our Piedmont Triad region. And I've published in this area. I've worked also looking at infectious diseases, most noted looking at respiratory infections as well as HIV in immigrant communities. I've worked with HIV and Latina women. I've also looked at HIV in sub-Saharan Africa. More recently, I've transitioned to looking at these emergent challenges that face our refugee and immigrant newcomers and longstanding neighbors in our Greensboro community, particularly looking at hypertension as an indicator of chronic stress and trauma, existing trauma. And now I've been looking at this mental health dynamics in the wake of COVID. And so community response is a very big focus. I'm interested in how these communities mobilize and respond to this emergency, this crisis. And I've published in the area of refugee and immigrant cultural adaptation in the wake of these kinds of issues. And I'm looking forward to learning more as things unfold.
Thank you, Dr. Morrison, and thank you all for introducing yourselves. I can safely say that we all come from very diverse backgrounds that have influenced our work and our research, and I think that's very important that it ignites that passion because we want to help our communities and in Guilford County as well and worldwide. So thank you. So so the second question for you all is, so what role do racism and race play in the landscape of health and human services and public health in the communities that you are researching and serving? I would like to start off with you, Dr. Monaco.
Thank you. So race and ethnicity are seen in the social sciences as socially constructed, which means that different societies actually develop notions about what race it is and what ethnicity is. For example, I am here in the US, put in the box of Latina, but really I have a Black and Indigenous people's heritage that I'm claiming and reclaiming as a sort of a mixed race background. But historically, race and ethnicity have been used actually as a weapon for also oppressing people who may be in either low levels of education, low levels of income, and in certain disadvantage. It could be ability, it could be other things. But in the case specifically of race and ethnicity, we have seen that it is actually being used to prevent people from accessing the type of social services that they need. In the healthcare field, we talked about health disparities because there is an inherent institutional racism that which is a systematic distribution of resources, power, and opportunities in our society to the benefit of people who are mostly white or predominantly in a position of power, and that exclude people of color. So COVID, we know that has impacted disproportionately the people of color because of those pre-existing conditions. And I'm not talking about just conditions such as the ones that are most well known, diabetes and so forth, but health conditions directly, but also that those conditions actually exist in disproportionately in the communities of color because of their social status, because of the lack of health care, the lack of insurance, to be able to, or even the lack of access to nutrition and health and appropriate food. If people of color live in the deserts, for example, in the food deserts, then they're less likely to get healthy food, so that there is obesity and some other conditions that are well known for existing in our community. So immigrants and refugees actually, I think, deserve to be welcome in this land of immigrants. Either in this land of immigrants, people from the very beginning have been seeking protection and joining family members from, the conquest actually in this country. So immigrants and refugees deserve to be treated with respect, and they need to be supported in order to adjust to a new home. This is why organizations such as the Center for New North Carolinians play an important role in supporting those newcomers to integrate into society in a healthy manner. And however, immigrants and refugees are not treated in that way. They confront a lot of racist policies, and as I said, institutional racism that with lower refugee quotas, for example, right now, not granting the right to apply for asylum even to those who are seeking protection, the child family separation that is very well documented by the media, and I've done some research and put in some publications as well. So to be inclusive, actually services need to be what we call culturally and linguistic appropriate. So for example, they need to attend the cultural background of people. If they come and don't speak the English, which is predominant language spoken here in the US, then the access to translation services are necessary. If they have problems with legal status, there should be then support for them to actually be able to regularize their status and then become contributors to this society. Specifically in the social work field, people of color are actually a minority serving a largely minority community. So we are not very well represented, actually, even in programs of higher education at the MSW and the PhD level. This is why I'm actually in a historically Black institution to be able to educate others in minority groups who can actually serve better this community, more culturally sensitive. And that is to address racism and ethnicism in the service institutions. And so what I teach and others in the program is actually to deliver those services in a multicultural context through community engaged research, dismantling then racism and ethnicisms as well as other isms.
Thank you, Dr. Monaco. Next is Dr. Abdu.
Thank you, Carmen, and thank you, Fatima. So, as Carmen said, the immigrants and refugees have been marginalized throughout the history of the United States, and they experience greater poverty, especially new refugee arrivals or newcomers, and therefore worse health outcomes and less health access compared to native-born Americans. When refugees arrive to the US, they arrive obviously with limited financial resources. These are individuals who have escaped persecution, sometimes by the skin of their teeth. And upon arrival, they receive Medicaid, but only for 8 months. And they're expected then to buy coverage or have a job that offers benefits after that time. But this is not really a realistic scenario for families who are still learning the language and the culture. Add to that undocumented or mixed status families have limited or no access to public benefits that provide basic economic support. In Guilford County specifically, 54% of non-citizen residents lacked health insurance compared to 16% overall. And the reasons for this are language barriers, their difficulty navigating complex systems, and of course, at times, eligibility requirements. But obviously, the system, therefore, is not built to accommodate and work with these newcomers from different cultural backgrounds. Additionally, both in Greater Greensboro and nationwide, immigrant and refugee communities are facing an increased fear due to shifts in immigration policy and community acceptance. So if we look at the recent policy changes, like the Muslim ban or the family separation, the executive orders, the lower number of refugee admission, the changes with DACA, and the proposed changes to the public charge, these have created stress and a dire effect on those who are seeking service among immigrants and refugees, because they're less likely to receive service given sort of the threats that they're sensing from those policy changes and the fear that these might affect their families. And the result of this toxic stress is the adverse health outcomes that affect them and their families for generations. We see through our work at the CNNC that many refugees and immigrants, regardless of their immigration status, are more reluctant to participate in health and social services. Some of them are voluntarily withdrawing themselves or family members from benefits that they're eligible to receive because they're afraid of sharing personal information that they think will be harmful to them and their families as well as their status. Others are limiting their time that they spend in public, which means that they're not taking advantage of opportunities like health fairs and community outreach. And of course, as I said, the refugee resettlement arrival numbers, which have decreased drastically and are projected to remain lower, also add to this. stress that affects health. So all of it together paints a really important picture of how the ways in which immigrants and refugees are racialized in this country, and the policies and practices that follow on that racialization are not only directly affecting health outcomes, but also the response to them is adding to adverse health conditions for generations. Thank you.
Thank you, Dr. Abdu. Dr. Morrison?
Yes. First of all, I want to put out there the American Public Health Association's declaration. And I think it's important because our public health field has, in general, been looking at race, ethnicity as variables or determinants of health. And so the American Public Health Association, the country's largest professional organization associated with the public's health, has loudly declared racism as a public health crisis, not just a problem, but a crisis. So what does that mean? It means that we've framed racism within health. And that's important because we're talking about systems that structure opportunities and assigns value based on a social interpretation, not a biological interpretation of how one phenotypically looks and appears. And in a way, this definitely unfairly disadvantages some and unfairly advantages others. So this backdrop is important for our profession to understand because racism, at the core of it, racism erodes health for all. And so this is an important piece as we begin to talk about our global to local scenario. It erodes health for all, not just the newcomers. And so it is eroding the hallmark and the core of the 1978 Declaration of Alma Ata, which is fundamental goal of our 21st century Healthy People 2020 and Healthy People 2030, under which we see that we are trying to make sure that we now reverse the kinds of injustices and discrimination that have been done to people of color. And more importantly, newcomers who are now coming into these racial categories and experiences some of the very same challenges as persons that are, and I use the word loosely, indigenous to the US community. So when we look at the landscape of health and those who fit within the US designated categories, we see huge disparities. And as my colleagues have talked about, this health disparities. In our field, we put a big focus on the social determinants of health. And when we start going across all social determinants, we see huge disparities, huge gaps, for example, in birth outcomes among people of color. Black mothers in particular have higher percentage of low birth weight babies. And oddly enough, when we look at the weights of African-born Black mothers, we see that their birth outcomes resemble those of Caucasian mothers. However, as we begin to racialize these groups and categorize them, we see a trend where now the gains that foreign-born Blacks have are being eroded because of bias, because of racism, because of discrimination. So when we think about this, racism impacts health on our transnational populations. As was mentioned before, for communities that I work with, I'm looking at some of the outcomes of this racialized health and racialized discrimination. And so we see physical and psychosocial impact on these individuals as they embody this xenophobia, as they embody the discrimination that they're feeling. We see growing chronic diseases, diseases that immigrants and refugees report they have not experienced in the high prevalence rates that they're now experiencing them. And then there's the pervasiveness of mental health issues that we see. And this is growing not only for the newcomers, but for the next generation, the second, third, and fourth generations. So these are some of the challenges when we start positioning and thinking about health of population based on race, and also based on this idea and notion of racism. It lends a question also to how are our services leveraging or reoriented to address the needs of our newcomers. And from the perspective of higher education, how are we reorienting ourselves to train up a next generation of newcomers to then take the lead in addressing some of these racial and ethnic disparities that we're seeing? So in my work, one of my goals is to make sure that I equip the next generation of public health professionals with the tools needed to go out there and fight for social justice on the behalf of the immigrant and refugee populations in our community.
Thank you, Dr. Morrison. I applaud you all for the work that you've been doing. I think for me as a graduate research assistant, one of the important things that we do is that, and that everyone does in this panel, is that we make these communities visible. And I think and they are invisible because of the structures and the systems that are in place. So I do admire you all, and you inspire me all for the work that you do. Um, so our third question for you all is, how have the communities you research and serve responded to COVID-19? Starting off with Dr. Monaco.
Thank you. Yes, again, as my colleagues and I were saying, COVID has impacted disproportionately people of color, and under the pandemic due to pre-existing health disparities, and some of them were mentioned. And there has been substantial research even prior to COVID that these conditions are actually associated with social and economic disparities, low income status, low pay jobs, lack of health insurance coverage, etc. But one thing that is also being in research is that a lot of these conditions, pre-existing conditions, are actually due to being subjected of discrimination and racism. Micro-discrimination is like a drop of rain over a roof. It really erodes. And over time, it really pays a toll, and it puts a toll on people's bodies. So it's important to recognize that a prior condition is discrimination and racism, which is not ending. And even during the pandemic, it has increased and continues because of the climate of elections that have taken place. So the high rates of infection and death are actually seen and observed now among these groups of people of color, who are the ones that carry on and do the essential and frontline jobs in health, in agriculture, in construction, in transportation, and in all of the service industries. So the people who provide groceries, we see that they're essential workers, but they're not paid at that level, right? So, and the majority of them are people of color. So immigrants and refugees are overrepresented in those jobs. And so they are the most impacted by the pandemic. And they are also affected by the high rates of unemployment that we see during this period, and the growing job insecurity that is taking place as well in the US, but around the world. And immigrants and refugees are actually responding with culturally embedded coping mechanisms, helping each other within and across families, within and across borders, tapping into their individual and collective resilience. The resilience is an important aspect for survival, and they are tapping into the historical ability that they have had to rebound from adversity, from the conditions that they left, and especially for new arrivals, and then for the conditions that they continue to face even after arrival. So they use the personal and social coping mechanisms that they learn as survivors of poverty, of war, of other pandemics, for the countries that they may come from, and from natural disasters. So there needs to be much more, I think, attention to the indigenous and Eastern medicine that immigrants may carry with them, and that have become really useful, especially when there is no access to proper health care. And we learn actually, or we have a lot to learn from the personal and social resilience that we have endured, which we have endured microaggressions and discriminations as immigrants every day. So as researchers, I think we need to learn more about this individual, family, and community resources and assets that this population has, and that can be used during the pandemic, and other colleagues will provide specific examples about that. But I'm making the point that it is through that collaboration at the local level within families and communities that we have been able to endure in this pandemic. In the research that I conducted globally, actually, I found that some of the conditions in which immigrants and refugees live, especially in refugee camps, prevent them from implementing some of the basic, World Health Organization or CDC guidelines. And when they are in confinement, for example, social distancing doesn't make sense. If they have no access to water and sanitation, then washing your hands and all of those things that are the things that we try to observe can be impossible. If they are in prison, and if they are in detention centers, they cannot have disinfectants because the high level of alcohol prevented those products from being used in those places. So I just wanted to call your attention then to the need to do even more research about those coping mechanisms and survival strategies that immigrants and refugees have.
Thank you, Dr. Monaco. I just wanted to keep everyone in track, and on time. We have a little less than 15 minutes, so let's keep our answers short and concise. So, Dr. Abdu?
Yeah, and so in terms of the communities that we serve, how they've responded to COVID-19, I want to speak to the specific communities that the CNNC supports, but also the CNNC itself as a community responding to COVID-19, especially our Immigrant Health Access project. And the folks that we serve, as I said, are uninsured adults, refugees and immigrants who are dispersed across Greensboro, but the majority of them live in zip codes that are considered COVID hotspots in Guilford County. So the infection rates are high for many of the reasons that Carmen stated. But when you're talking about folks living in less than desirable housing conditions, where quarantining, self-isolation is not possible, when you're carpooling to go to work, when your work conditions are not allowing for health protocols, and when you're an essential worker in poultry plants and packaging and processing plants, then the measures that are expected to be taken cannot obviously be implemented. And I want to say, to reiterate, that racism in itself is a pre-existing condition. And so what's happened is that these health disparities that were already being experienced by immigrant and refugee communities, they've only become more visible. It's not like this is new, right? It's just now that we see them increased and more apparent against the backdrop of COVID-19 and this renewed attention to this vast racial inequity across the systems in this country. And we at Immigrant Health Access have played a key role in responding. So we've worked with state and local partners to translate public health education materials Again, this goes back to race and racism. Adequate interpretation services and accurately translated written materials remain lacking in many local health settings. And so it's key for us to be able to translate so that this material is linguistically accessible. We also are seeing that we're responding to increased needs related to social determinants of health, especially as folks raise concerns about housing, about unemployment, about workplace safety, about food access, and other concerns. The staff at the CNNC have noted firsthand that COVID-related challenges disproportionately affect Latinx and Montagnard communities, especially as well as the many immigrants and refugees working in high-risk occupations. But what we've tried to do is provide the community with a trusted source of information and support to address those needs directly related to COVID-19. And that, of course, will last much longer than the pandemic, right? Post-pandemic, there'll be a lot of ripple effects. Thank you.
Thank you, Dr. Abdu. Followed will be Dr. Morrison.
Right. So what I'll do is provide a concrete example of how the communities I work with are responding. And so I've worked with the Montagnard community, again, a longstanding refugee origin community, as well as the Bhutanese refugee community. And these two communities have leveraged their academic community partnerships. And so working with these partnerships and at the grassroots level, they've been addressing COVID in very innovative ways. Building on that concept of their own resilience and know-how coming from trauma that evolved from conflict regions that they occupied during many, more recent times and even 30 plus years ago. And so with the Montagnard community, what we see is them leveraging their academic partnerships, their youth, and the know-how of what they've done before to address things like food insecurity, housing issues, job readiness. And they have repurposed all of these linkages. And so for a concrete example, they've been working with the first and second generation of what we call college educated youth coming from their communities to leverage social media to get culturally appropriate and responsive messaging out. And so they've now engaged their elders in Zoom calls. They've engaged their leaders in Zoom calls to discuss the state of the community. They've also used social media to get simple, straightforward prevention messages out there, as well as use social media to fundraise, as well as help folks understand the myriad of paperwork that goes with applying for financial resources in times of hardship. I've seen them also work alongside each other. And so we've got cross-pollination. So now we have refugee communities collaborating across with each other to share resources addressing food insecurity, finding ways to social distance in families in intergenerational households. So for example, raising funds to pay for hotel rooms that they can then put family members in and make sure these family members feel secure when they have to be socially distanced or quarantined. So these are some of the innovative that communities that I'm working with are responding. And now they are moving into looking at the issue of distress from having to do homeschooling, as well as just not gather in spaces that they're used to gathering. And so they're finding alternate ways to create this social support.
Thank you, Dr. Morrison, and thank you all. You all bring very I see a reoccurrent theme of I think the social determinants of health, and I work with Dr. Morrison, so I've seen this firsthand how communities have mobilized in response to COVID-19, and I think it's not it's it's not a it's not a factor that's overlooked, but I think that's a factor. Is mental health. Um, I think it's a factor that people are a little scared to touch on just because we're dealing with families, and there's a lot of generations, and there's elderly, and they're not willing to talk about that. So thank you all. Our last and final question is, what does it mean to decolonize global health in the context of your work and the communities that you engage with and research, serve, and support? Starting with Dr. Monaco.
Yeah. So because we only have about 5 minutes, I just wanted to speak for a minute and kind of conceptually, and then leave my colleagues to speak more with examples. But colonizing is conquering another civilization, and decolonizing is deconstructing those institutions that were created during the colonization. So what's this mean in terms of the global health context? Dismantling actually the racism and other isms that are inherent and are sometimes invisible in our social services institutions. It is actually being able to align the resources to the communities that are least in advantage, instead of profiting, those who may be having a lot of at stake in terms of financial investment. So most contemporary pandemics have emerged from our exploitative relationship with Mother Nature. So we have a lot actually to learn from communities of color, and specifically from Native communities, including immigrant communities that come from with an indigenous background, in changing that relationship and preventing actually future pandemics. So we have a lot to learn from these communities, and decolonizing is about learning from those different ways of looking at the world, the cosmovision. So this colonizing in social work is consistent with our core values and of social justice, self-determination, worth and the dignity of people. And to do this with deliberate and multicultural services, those that are sensitive to the cultural background of immigrants and refugees. And under the pandemic, then we need to find ways to get the message right and effectively into the community, translating it into the messages, so that people can actually learn from also that kind of transmission and important health information that is needed. But it's not a one-way messaging. It has to be also learning from the community. Thank you.
Thank you, Dr. Monaco. Dr. Abdul?
Thank you. So I want to say that decolonizing is about many things, but for me, it's about access, agency, and advocacy. And one way that we do that at the CNNC is through the community health worker model, which I think is inherently grounded in equity, right? It understands that a universalized one-size-fits-all approach to healthcare is not universal and fits only certain groups, privileging their experience as the standard over others, for whom the landscape of healthcare remains barrier-ridden. So the community health workers are actually members of the immigrant and refugee communities that they serve, and they have the language abilities and the cultural brokering expertise to be able to build those deep relationships, that rapport, that trust with the communities, to create a safe space for folks to tell those stories, Fatima, that you were talking about, that that they don't want to talk about to others, to be able to disclose needs that are related to mental health, domestic violence, and other stigmatized experiences, as well as physical health, social, and economic needs. So we work to ensure that clients not only have access to services, but that they develop self-advocacy skills to request interpretation, right? And that they connect them with community-based providers, in some case accompanying them to appointments to provide psychosocial support and accurate information about eligibility, and to maintain relationships. We also refer our clients to community resources that assist them with their needs. And so working, multi-pronged approach, as Carmen has said, to recognize the agency and resilience and resourcefulness that's already there, and to build upon especially the self-advocacy piece, while also ensuring access and linguistic appropriateness and cultural appropriateness on the service provider end.
Thank you, Dr. Abdu. Dr. Morrison?
All right. Well, from the public perspective, decolonizing global health is keeping your eye on social justice. And by that, I mean looking at equity, equity where all have access, but all have access in a way that they can utilize that access to the best to promote their health and well-being. And so in decolonizing work, I have two different approaches. One is the approach to my research, which is community-based participatory research. And in that, there is co-learning, co-decision making, co-sharing, co-everything. And while that might be a pie in the sky approach, what it does is, again, the agency and the advocacy and the voice, centering the voice, the priorities, and the understanding and the knowledge production with those who are being studied. Often we study people, but we don't engage them in this conversation or in the decision making or in the methods that we use. And so my work with local communities aligns with community-based participatory research. My second approach is to work with who I call the cultural experts, and that's the students in front of me. And so decolonizing our curriculum, the way we train individuals to work with these communities. We recognize the experts. They're not just students, but they are the experts in what daily life looks like, training them up, offering opportunities. Many of our students from refugee and immigrant communities are invisible and are left out of scholarship opportunities, fellowships, awards, and these kinds, or they're not the first pick when it comes to seeking out a research assistant. And so decolonizing means giving them voice. They are good teachers, probably better teachers than we are, looking at our local scenario and training their peers to work in these communities, to do culturally responsive work. And so that's a whole different model of looking at decolonizing in the way we work with academia, that we've been perpetrators of this colonizing. And so we are now working to deconstruct and train up a 21st century professional that has culturally responsiveness, sensitivity, and a sense of collaboration for social justice.
Thank you, Dr. Morrison. And that brings us to the end of our questions. I just wanted to say thank you all very much. You all brought on very insightful statements and ideas for me to think about. I agree with you all. I think Dr. Morrison said that it's very important to engage with communities through a community-based participatory research. I think that's something that researchers, I heard once a student say that sometimes researchers enter communities with this white savior complex, and that's very harmful and that's very detrimental to communities. And I've also seen this in my coursework as well, where well we are encouraged to I think in my evaluation class, we were taught about evaluation methods. And one of the evaluation methods, when, for example, for Native American populations, they're not, sometimes they're worked at, but they're not worked with. So thank you all. And does anybody have any final comments, anything that you would like to ask or add?
Thank you, Fatima,
Thank
for
you.
Thank you,
steering the
Fatima,
process.
Thank you. Thank you all. Thank you.
for
I
facilitating. Excellent. Thank you so much. And thank you to my panel, my peers, for your insights.
Well.